To start the proceedings, I invite Dr. Lalitha Pereirasamy to talk about the chronic cough. Thank you.
Thank you very much, Mr. Chairperson. Ladies and gentlemen, very good morning to all of you for being here on time. I am Lalitha from Penang General Hospital, Malaysia. And I would like to take this opportunity to first thank the organizing committee of Respire 2025, Dr. Niranjan and team, for extending the invitation to Malaysian Thoracic Society. We are very happy and honored as well to be part of and to be contributing for the academic sessions this year. And we also look forward to further collaborations between both societies as well as country, I hope. And along with the invitation came this topic as well, for which I need to be presenting on, which is chronic cough in adults beyond the basics. So what I intend to do in the next 25 minutes or so is to very quickly go through the introduction, the cough reflex pathway, the guideline diagnostic approach, as well as share a few cases from our practice, and then conclude off going through what is cough hypersensitive syndrome, as well as its current therapeutic landscape. So I came across this proverb. Is a Yiddish proverb. By the way, Yiddish is a language dating back all the way to the 19th century. It goes like this: 3 things can't be hidden, which is coughing, poverty, and love. All right, so I think it's one of a proverb which grows on you slowly. Nevertheless, there's a lot of truth to it, because cough is indeed one of the commonest presenting symptom of a patient to seek medical advice. So that's because it's highly impactful, psychologically, socially, as well as physically. There are a lot of consequences for this patient, and so you really can't hide. Globally prevalent problem affecting about 10% of the population. There is country-to-country variation, simply secondary to difference in diagnostic criteria being used. But what is evident is there is a geographical difference, a higher prevalence among Caucasians as compared to Asians. And despite a meticulous diagnostic protocol for chronic cough, about a third of them may remain unexplained or refractory, which brings us to the definition of chronic cough. So based on current cough guidelines, chronic cough is defined as one lasting more than 8 weeks. A cause is identified in most of these cases, and they have resolution if a subsequent cause-specific therapy is administered for such patients. And when, despite addressing these treatable traits, the cough persists, it's then termed refractory. And when you cannot find a plausible cause for it, then unexplained. Both RCC and UCC, these patients may exhibit symptoms suggestive of cough reflex hypersensitivity. And then there's this terminology called cough hypersensitive syndrome. Now, this was first published by the ERS task force in 2011. It's a disorder characterized by exaggerated coughing, and the patients are exposed to innocuous stimuli, often by low levels of thermal, mechanical, as well as chemical exposure. What is increasingly being identified is that it has a neuropathic sort of a mechanism to it, with both central as well as peripheral mechanisms. What we do know about cough is it's a vital physiologic protective vagal reflex, and it contains 3 major components, which is the afferent sensory limb, the central respiratory or central pattern generator, as well as the efferent motor limb. And so cough is mediated by sensory vagal fibers, which are innervating the proximal airways, larynx, and you will probably also find them reports saying esophagus as well as the ear canal as well. And they're broadly divided into the chemically sensitive C fibers as well as the mechanically sensitive A delta fibers. So cough, basically, when these airway sensory nerves are activated in response to stimulus, which travel through the internal laryngeal nerve, superior laryngeal nerve, as well as the vagus nerve, and then terminates at the nucleus tactus solitarius, which is at the medulla. And then the respiratory central pattern generator modifies the activity of the inspiratory and expiratory muscle and leads to cough. So the efferent pathway is actually again with the vagal nerves as well as the spinal nerves from C3 to S2, and then, of course, phrenic nerves as well, and result in this expulsive reflex called cough. So in cough hypersensitive syndrome, it is hypothesized that the peripheral pathway is exaggerated, is sensitized, is hyperexcitatory, and the central pathway, the patients actually have loss of this voluntary reflex on inhibition of cough. And so the entire cough reflex arc is exaggerated. So according to BTS, the recommendation right now is to have a general terminology, chronic cough, for the patients presenting, and then outline the contributing factors in those patients based on evidence, right? And so this approach is practical, facilitating a precision medicine approach. And then you then direct the therapy according to the treatable traits identified, and also helps us recognize the variable contribution by a spectrum of diverse phenotypes, which may be present in a single patient. And the traction also is to evaluate objectively the symptoms of the patient pre and post intervention with cough measurement tools, either by using symptom-based, which is usually the visual analog scales, or via health-related quality of life. And in trials, they use objective assessments with chemicals, exaggerating the cough reflex sensitivity. Okay, so this is also being recommended by guidelines right now. So guideline-based assessment process should include an initial assessment. I'm sure all of you do this. History examination of the upper airway, respiratory, as well as the cardiovascular system, with particular interest on red flag symptoms, which would warrant a more urgent referral or even investigation or special tests in these patients. And of course, basic tests like chest radiographs, spirometry, as well as evidence of T2 inflammation in the airways. And if you do identify an underlying disease, whether airways or interstitial lung disease, treat it accordingly. Remove the aggravating factors, smoking most of the time, or even iatrogenic cough by drugs. Then consider further tests in these patients, depending on what's the provisional diagnosis. And if you have an immune competent patients with no obvious cause, be it from history or even the initial examination or investigations, and then look out objectively for these common causes instead of empirically starting therapy. So only treat if there's objective evidence of these common conditions, and make sure you treat accordingly, and hopefully the patient actually will have resolution of their cough. So I'm going to go through a few cases, which is of particular interest from my practice, with some key learning points from a personal point of view, and maybe hopefully for you too. What I would like you to do is hold your thought based on these the cases I'm going to be presenting, maybe have your own provisional diagnosis, and maybe how you would work out your patients while I share our story. So the first patient is a 70-year-old man, a retired health inspector. He was basically involved in the infection control part for dengue. And so he was exposed to for the chemicals used for fogging, for anti-dengue. Otherwise, he was a very fit patient, a marathon finisher, lifelong non-smoker. In 2021, he came down with pulmonary tuberculosis. Around about the time, he was also diagnosed with CA prostate. He was treated for both the conditions. In August 2024, we received the referral from the general practitioner for persistent coughing for 1 year duration. By that time, the patient had already received dual bronchodilators from the GP, purely for a diagnosis of COPD, which was symptom-based. There were no spirometry done at GP level. So patient was still symptomatic. There's nothing else remarkable in this patient, except for the history of GERD, for which he was already under follow-up with the surgeons and on treatment. That was the first case. Second case, we have a 53-year-old patient who presents with productive cough for 1 year duration. There are some red flag symptoms here, intermittent fever. He's been treated with multiple courses of antibiotics for infection. Again, lifelong non-smoker. Only thing else which was positive in the history was he was a construction field worker with exposure to silica for at least about 20 odd years. And I've got a third case. Now, this case She was a 45-year-old lady who was referred to us to the severe asthma clinic for difficult to treat asthma on step 5 management on multiple inhaler triple therapy. Retrospectively, I would say she had this classic episodic bursts of coughing for 6 months duration. She had a lot of laryngeal symptoms, throat discomfort, tightness, voice change, which was always preceding the episodes of cough as well as wheezing and breathlessness. She had a lot of nasal symptoms as well. She reported having sensitive to strong odor as well as had persistent allergic rhinitis. She was a recent divorcee underlying bipolar disorder and was morbidly obese with a BMI of 32. Let's now look at how we navigated these cases. Case 1 again, just a summary, chronic cough, predominantly dry cough in this patient who did not respond to dual bronchodilators. So what we did in this patient is we certainly had to exclude relapse of tuberculosis in him, TB being endemic in Malaysia, and his past history as well. But the initial microbiology was negative. Chest radiograph was clear. CT did not show any evidence of airway disease, interstitial lung disease, or even lung nodules. What we did find was a sliding hiatus hernia, which did not really explain his symptoms. Spirometry was normal, no obstructive pattern. Bronchodilator reversibility testing was negative. But what we did find in the next investigations was evidence of T2 inflammation in the airways. FeNO was elevated, and his multiple point serum eosinophil was also elevated more than 300 cells. And the diagnosis in this patient we made was non-asthmatic eosinophilic bronchitis. And the patient responded very well to inhaled corticosteroids. We switched him from dual bronchodilators, and he made marked improvement in his symptoms. So the key learning point for us was common things are indeed common, but still make efforts to have an approach towards identifying the disease entity and treat them with objective evidence instead of empirical therapy. And then you may likely have a resolution for your patient in symptom-wise, they may improve. The second case is a patient with wet cough. The earlier patient was a dry cough, and this one is wet cough with intermittent fever. We were considering most likely tuberculosis as well as bronchiectasis in this patient, but microbiology was negative. We proceeded with a bronchoscope for this patient, which is where we find this peculiar findings, whereby his airways were narrowed. There were a lot of nodular whitish nodules which are protruding into the anterolateral wall of the tracheobronchial tree and was sparing the posterior fibrous wall. And biopsy of these lesions showed fibrocartilaginous tissues with central islands of osteocytes. CT also further confirmed this nodular calcified excrescence at the anterolateral tracheobronchial tree. So this was the first case we had come across as such. We could talk about it if any one of you may have seen as well such case. We ended up publishing it with the Journal of Respirology, APSR. It was a case of tracheobronchopathia osteochondroplastica, quite a mouthful, but it's fondly known as TO. So this is the macroscopic appearance of the flexible bronchoscopy for the patient. You can see how the nodules are just crowded around the areas where cartilage is found and how the posterior wall, fibrous wall is actually spared. CT showing varied degrees of stenosis as well. So how we approached this case was we then subjected him for pulmonary rehabilitation as well as airway clearance therapy. He did very well with this handheld device called Aerobica. He still has cough, maybe a 50% reduction in his symptoms, but certainly not coming down with recurrent infections. So the key learning point for us was chronic cough is fairly ubiquitous in respiratory diseases beyond the commonly associated comorbidities. So on a personal point of view for me was seekers are finders, isn't it? Anyway, with a little caution to be mentioned in such cases, why I put up this case is that in patients with productive cough with an identified pathology, be it lung pathology like bronchiectasis or in this particular case, TO, also in neurological conditions, the aim is never to abolish cough, but maybe to reduce and help the patients deal with their symptoms and have a better quality of life as well. Now, the third case, I must say, she was quite a nightmare for us. It took a long time before we actually found a solution in her. She was labeled as difficult to treat asthma on step 5 management. She had multiple unaddressed comorbidities and risk factors, as how you'll find on the bottom table, really multiple. And for sure, she had evidence of T2 high asthma. So despite addressing each and every one of these risk factors and treatable traits, if you'd like to call it as such, the cough was still there. It was classic, a lot of laryngeal symptoms. So we were at a junction of considering, is this a case of refractory chronic cough, or should we consider biologics in this case, right? Because she did have multiple causes of oral corticosteroid bursts as well during these episodes. And we had multiple MDTs, multiple discussions among teams, especially ENT, during one of the evaluation. Then it was found that this patient showed involuntary adduction of vocal cords during inspiration. And then we made a diagnosis of vocal cord dysfunction. She was then subjected for vocal cord speech therapy, as well as some psychological behavioral intervention as well. But nevertheless, she's still under a radar for biologics. So in this patient, what I want to highlight is that several treatable traits may coexist in one patient. And despite having so many of them, the cause may not be readily obvious. Patient may still have continuous cough. So repeated evaluation may be required. And, we should still try and ask, is there any other investigations to be done? What else can be the cause before we label them as RCC or hypersensitive syndrome? So then, of course, we've investigated every patient and everything fails. What's next, right? So we come to the story of cough hypersensitivity syndrome. Now, in literature, you will also find it being interchangeably referred to as refractory or unexplained chronic cough. So the major guidelines addressing this will be the ACCP, ERS, as well as BTS. And this is the algorithm by the ACCP 2016. When you do have a patient with potential RCC, instead of immediately going into therapy, always ask yourself, is there any remaining investigations to be undertaken? Were trials of therapy optimal? Was the patient adherent? Before making the diagnosis of difficult to treat cough and considering neuromodulatory agents in this patients, or speech and speech therapy intervention, or even considering recruitment into clinical trials. And based on analysis of all these RCTs, the expert panel for ACCP, they actually recommend the neuromodulator to be used is gabapentin. And this is because of the huge concern of opiate dependence and opiate abuse in the US. So, which is a little bit different from ERS guidelines. This was in 2020. The neuromodulatory agent, which is recommended by the ERS, is a trial of low-dose morphine, 5 to 10 milligrams daily in adult patients with RCC. It comes with strong recommendation, moderate level of evidence, and they say that about 50% of the patient may respond. But one thing to note is that in responders, the treatment response is very rapid and clear, usually seen within a week or two. And so discontinuation, you should always consider discontinuation if there is no response in 2 weeks. And this would avoid the problem of dependence and other issues. And the other one, which is recommended, is the gabapentinoids in this patient. Of course, the strength of recommendation is conditional with low level of evidence, because they do find that the response rate to opioids is much better as compared to gabapentinoids. So this is the summary table of neuromodulators in chronic cough. How about the other drugs, right? Now, we all know that agents like tramadol, codeine, dextromethorphan, amitriptyline is more easily available, less probably restrictions, especially in countries like mine, and probably more used rampantly in a lot of patients. But the problem is there is evidence. However, there are also more conflicting evidence, and hence the major guidelines neither recommend nor discourage the use of these drugs. So we certainly need either more evidence or, something like that. But what is the future? So this is The traditional approach was targeting central targets, and now the approach is actually shifting to look at the peripheral targets. And this is because there's increased understanding about the neuropathophysiology of chronic cough. And also it's felt that there's hyperinnervation in these patients, and biopsies, endobronchial biopsies in patients with RCC have showed them to have increased nerve branching as well as densities in these patients, in particular patients. So the antitussive therapies developed in recent years are actually looking at this peripheral nervous pathway, either by blocking their activation or reducing conduction of action potential. So one of the receptors which has gained a lot of interest is P2X3 at the vagal sensory afferent nerval pathway. It is now being called as gefapixant. It's received a lot of attention since late 2023 and now FDA approved in EU countries as well as Japan. It was originally planned to be developed as an analgesic, but it has been found to have significant effects in patients with RCC. So it is a selective P2X3, but there is also a little bit of cross-activity on this other receptor, P2X2/3 receptor antagonist, which is important to why it has a side effect profile which is more taste related, right? So these receptors are ATP-gated ion channels, which are in the afferent neurons, as I mentioned earlier, which have got this vagal C or adelta fibers. So this is an analysis of the RCTs from 2023 onwards. It's rather recent, and they looked at gefapixant compared to placebo in terms of 24-hour cough frequency, as well as cough severity and cough-related quality of life. And as all these forest plots show you, it was favoring gefapixant. But what was also found is there was an increased risk of this treatment group with side effects, particularly the taste-related adverse effects. And that was because of this, although it was quite selective, but it has this other, a little bit of more activity on the other receptor as well, which is found on taste buds. Okay, so both therapeutic and adverse effects were dose-dependent with a cutoff dose of 45 to 50 milligram twice daily. This drug is not available in Malaysia, no personal experience using it. This is the guideline recommendation. You may be hearing it in future. So there are now numerous targets for novel therapeutic agents in the field of RCC, and one which is showing a lot of positive, encouraging, lower side effect profile is this drug called camlipixant, which is more selective with its P2X3 antagonism. But there's certainly many other peripheral as well as central pathways which are being now studied upon. Future, probably we will have more data. They're looking at not only RCC, but also in patients with IPF and how to improve their quality of life or reduce their problems with chronic cough. Non-pharmacological management, I would say this is actually one of the landmark trials back in 2006, which was published. They looked at intervention strategies, which included education, strategies to reduce cough, laryngeal irritation, as well as psychoeducational counseling in these patients. So there was significant improvement compared to the patient's pre and post intervention. And so most of the major guidelines right now incorporate speech pathology, evaluation, and therapy as an effective management, as an add-on therapy to medical neuromodulators, or even in patients as an alternative in patients who fail or do not respond to medical therapy. So certainly it worked with our third patient. What is interesting now is not only looking at newer drugs, newer receptors, but also a lot of efforts which is put in to establish basic standards in how one would approach chronic cough. Although, we may actually take it lightly, but it does have a lot of consequences for the patient. So this is good. And I hope we can also look at it and probably do the same at our local practice. So in conclusion, chronic cough is an impactful condition. It's now considered a disease entity on its own with hypersensitivity reflex. And despite increasing understanding on the neuropathophysiology, chronic cough, the treatment options in chronic cough is still limited, although we are now seeing an expanding range of both central and peripheral neuronal targets. So we still can't avoid the fact that there remains much to be learned as well as challenges to overcome for these patients. So I come to the end of my talk, but I would also like to take this opportunity to invite and welcome all of you to Malaysia, Penang, which is an island as well, to the 30th Congress of the APSR. So please save your dates, mark your calendar, 19 to 22nd November 2026. It will be in Georgetown. And so I hope to see all of you then. And I thank you for your kind attention and very happy to take any questions. Thank you.
Thank you, Dr. Pereirasamy. Before we open the forum for the questions, there are two questions online sent on the virtual by a virtual registrant. Number one is, obesity has been given as a treatable trait on BTS guidelines. Is this secondary to reflux disease? Do we have any evidence to state direct relationship between cough and obesity? So
obesity and reflux, is it?
Yes, obesity. Cough.
Yeah, obesity actually, it seems to be a phenotype which seems to be appearing now in many of the diseases, including asthma as well. So chronic cough, it seems to be a separate phenotype. It is associated with obstructive sleep apnea and probably increased risk of reflux. But on its own, actually, there's still a lot more to be understood, and it's now being considered as a risk factor on its own and not only related, probably related as well, but on its own as a treatable trait.
Yeah, that's exactly what this participant wants to know. And then another one on the second case, as there was chronic productive cough, which was persistent despite airway clearance, is there a place for macrolides? That's a question they want to ask you about the second case.
Yeah, thank you very much for that question. But macrolides is something in our country, we have to deal with tuberculosis. And so we've got to be extra careful with macrolides. And macrolides, the evidence is basically for chronic bronchitis, not really in these kind of patients where you may have. So you have to, that's why they think that you need to have an evidence-based approach to identify the disease and not start them all on empirical therapy. And then you would find consequences of your therapy with no resolution of symptoms. So this is why the current recommendation is to make the extra effort to identify, especially in wet cough, what is the cause, because that is indeed a red flag symptom. So macrolides in TB endemic countries, it's a total no unless you have proven that, you're not dealing with tuberculosis, and also the evidence is for chronic bronchitis, COPD.
We have another couple of minutes for a couple of questions.
Very excellent presentation on chronic cough.
Thank you.
My question is that actually I have two questions. Is cough hypersensitivity and sensory neuropathic cough one and the same? That is one question. We know this prodrome and the non-specific triggers in sensory neuropathic cough. The other question is that this chronology of 8 weeks for chronic cough, can it happen much earlier? Should we look at prior episodes where a patient had a viral illness and then had this non-specific triggers and a neuronal prodrome? Should we stick to 8 weeks to diagnose chronic refractory cough when it comes to neuronal hypersensitivity?
Okay, so the first question was sensory. I think there's a lot of terminology. If you look at it, there's a lot of terminology, which is going on. And even the literature right now, there's really a lot of different ways of actually calling the same disease. So I think what you try to say, the second reflex, whatever it is, the mechanism is about the same, and it's hypersensitization of the peripheral and central pathways. So basically, I think it's just terminology. The second one you tried to ask was on should it be earlier, a diagnosis in patients who present with acute cough. Again, acute cough, they usually have resolution within 4 weeks of after that, and failing which you should investigate. Now, refractory is when you have already identified treatable traits, treated them, and still cough is persistent. So it's not to do with the duration, but to identify the particular treating traits. So I don't think it's just the duration before you call them refractory cough. Yeah. So they should not have responded to the commonly, which is the risk factors.
The other aspect is that we see is laryngopharyngeal spasm, which presents quite dramatically. And my understanding was ILO present or inducible laryngeal obstruction, VCD. It's more a dyspnea dominant, breathing dominant presentation. Can you make a distinction between ILO, inducible laryngeal obstruction, or VCD, and laryngopharyngeal spasm?
Actually, if you look at this thing, the guidelines or even the literature which is present, they may have symptoms of stridor, but a lot of laryngeal symptoms is also being described in this group of patients. So also the phenotype of the patients having more women, as well as, with having some social background to it, also they seem to relate it to suspicion of this. The only problem with ILO or VCD, I find, is it's rarely a diagnosis made by the pulmonologist, and we very much rely on another team, which is the ENT. There is evidence now to use CT scan, but still, I think to your question, they do present with upper airway obstructive symptoms as well. But also there is another group which may present just with this type of classic laryngeal symptom cough.
Can we squeeze in one question?
Thank you for a nice presentation. Can you throw some light? Of late, we are seeing a lot of refractory cough in ILE. How do you manage? Is it in a way different in the management with what you are told?
Yeah, this is a very difficult section, basically. Thank you for that question. I do interstitial lung disease work as well. And this is really in IPF quite a difficult thing. So in these patients, especially with fibrotic interstitial lung disease, we do use a low dose of opiates in this group of patients. And but otherwise, the patients are really symptomatic, very difficult area, not much of evidence yet. They are looking at it. But in my practice, in our practice, very, very low doses. And most of these patients also in Malaysia, we are detecting them pretty late. And so they're also in the palliative intent of management. And hence, opiates do come handy.
I'm sorry, Ruanti, I think we'll have to stop the session for the interest of time. I think you can ask the question.
Yes, you could always come to Malaysia,
Thank you. So we'll close the session because for the time. So thank you for the interesting presentation.
Thank you very much.
The discussion.
Thank you, ma'am. Your insights will surely expand our understanding of chronic respiratory issues. Let us now take a moment to appreciate our speaker, Dr. Lalitha Pereirasamy, with a token of appreciation and a certificate. I invite Dr. Geeta Pereira and Dr. Sundaralingam Risikesavan, the honorary chairperson, to deliver them.